Hi lovely people, in this part we'll discuss few more topics pertaining to NEET MDS 2019 paper discussion, starting with the previous video's topic. We ended the previous video with fluorides in cavitated lesions, right? So one of the aspirants has given me more keywords pertaining to this question. So the question is, which of the following fluoride would remineralize a cavitated lesion? Silver diamine fluoride, APF, and rest of the options which the aspirant doesn't remember. So when I reviewed literature, silver diamine fluoride is something which is used for remineralizing cavitated lesions, right? So we'll go through some literature now. Silver diamine fluoride is used for caries arrest and as well as treatment of dentin hypersensitivity. Dental caries is a complex progression involving various factors. The collagenous organic matrix is exposed once dentin surface is demineralized and destroyed by native and bacterial proteases to enable a lesion to enlarge. Upon application of silver diamine fluoride to a decayed surface, the squamous layer of silver protein conjugate forms on the surface of a lesion, increasing resistance to acid dissolution as well as enzymatic digestion. Hydroxyapatite and fluorapatite form on the exposed organic matrix along with presence of silver chloride and metallic silver. The treated lesion increases in mineral density and hardness while the lesion depth decreases. Meanwhile, silver diamine fluoride specifically inhibits the proteins that break down the exposed dentin organic matrix, that is matrix metalloproteinases, cathepsins, bacterial collagenases, etc. Silver ions act directly against bacteria in lesions by breaking membranes, denaturing proteins, and inhibiting DNA replication. And that's antibacterial action pertaining to silver. So it's clearly mentioned that upon application of silver diamine fluoride to a decayed surface, the squamous layer of silver protein conjugate is formed, and this layer is resistant to acid dissolution as well as enzymatic digestion. Hydroxyapatite and fluorapatite form on exposed organic matrix, and the treated lesion increases in mineral density and hardness while the lesion depth decreases. So these are some justifying statements which we have pertaining to the same topic, right? I hope it's clear. Now moving on to the next topic, I reckon there was a question on passivation. Which of the following metals or elements is used for passivation? So as you know, chromium is something which is used to form a passivating layer in order to prevent further tarnish and corrosion. So we'll review some literature pertaining to this topic. Chromium is required as an alloying element in iron, nickel, cobalt alloys to provide passivation of alloy through formation of thin surface layer of chromium oxide. So we have different types of stainless steels. Chromium, which is a component of stainless steel, forms a very thin, transparent, adherent layer of chromium oxide through a process called passivation, which provides a barrier to diffusion of oxygen and other corrosive species and prevents further corrosion of underlying alloy. Right? In fact, we discussed about tarnish and corrosion and passivation concept previously as well. Right? Moving on to the next topic. There seems to be a question on back action periodontal instrument, right? So options, I reckon, Gracie's Curette, Rhodes, whatever. So periodontal bone chisels, Rhodes back action. So we have an instrument with back action. I'll just review some literature. As you can see the image now, periodontal bone chisels, they're stainless steel dental instruments used for removing as well as recontouring bone. Rhodes back action is designed for use with pull stroke. It is ideal for removing bone adjacent to the tooth without causing trauma and is especially useful on the distal aspect of the last molars with working ends of 3.8 mm width. Right? So this is some information pertaining to Rhodes back action. It's a chisel which is used for removing as well as recontouring bone, periodontal bone chisels. Right? Now moving on to the next topic. Gingival sulcus, is it completely permeable, semi-permeable, what? So there seems to be a question on the same. Gingival sulcus is non-permeable, semi-permeable or permeable. So if you refer Karanja, it's clearly mentioned that gingival sulcus is semi-permeable. The sulcular epithelium is extremely important because it may act as semi-permeable membrane through which injurious bacterial products pass into the gingiva and tissue fluid from the gingiva seeps into the sulcus. So gingival sulcus is semi-permeable, right? Now, another question on which of the following is an aggressive cyst. I'm not sure of the options, but when I reviewed literature, obviously dentigerous cyst, even OKC in Schaefer's, it's mentioned that these cysts are aggressive in nature. We'll review some literature. So dentigerous cyst can be defined as an odontogenic cyst that surrounds the crown of an impacted tooth, as you all know. So it's clearly mentioned that dentigerous cyst is potentially capable of becoming an aggressive lesion. Expansion of bone with subsequent facial asymmetry, extreme displacement of teeth, severe root resorption of adjacent teeth, and pain are all possible sequelae brought about by continuous enlargement of cyst. Right, so it has potential to become aggressive. And also coming to odontogenic keratocyst, as you know, it's a cyst derived from the remnants of dental lamina with biologous behavior similar to that of benign neoplasm. So it's clearly given that it has distinctive lining with 6 to 10 cells in thickness, and in literature it's also mentioned that there are unique odontogenic lesions that have the potential to behave aggressively. Right, so let me know what the options are. So based on that, we can come to a tentative answer for this specific question. Right, moving on to the next topic. Brown tumor is associated with which of the following lesions? I think that was a kind of question you had. Or brown tumor is related to all except. So if you review literature, it's in case of hyperparathyroidism as well as in cases of peripheral giant cell granulomas. And for information, brown tumors are giant cell focal lesions that arise as a result of abnormal bone metabolism in patients with hyperparathyroidism. The lesions localize in areas of extensive bone resorption, which is replaced by fibrovascular tissue and giant cells with abundant deposits of hemosiderin, and also there is hemorrhage. So it's a radiographic feature, right? Radiographical also you can evaluate these lesions in patients with either hyperparathyroidism or peripheral giant cell granulomas, right? Moving on to the next topic. Platelet count and spontaneous bleeding. So if you review literature, it's given that platelet count more than 50,000, it's all fine, but less than 50,000, precautions have to be taken. And there can be spontaneous bleeding when the range is between 10,000 to 20,000, right? And greater chance of bleeding when the platelet count is less than 10,000. So we'll go through some literature. Thrombocytopenia is defined as platelet count below 150,000 per microliters, right? And typically platelet counts higher than 50,000 50,000 per microliter, right, do not lead to clinical problems unless platelet dysfunction coexists with low count. And it's also clearly mentioned that medical help is usually sought by a patient with platelet count less than 30,000 per microliter, or suffering from spontaneous bruising, purpura, or with continuous or relatively long-lasting bleeding from injuries or wounds. Clinically significant spontaneous bleeding does not usually occur until the platelet count is less than 10,000 per microliter, 10,000 cells or platelets per microliter, right? Now, moving on to the next topic. Posterior palatal seal recording. So as you can see in the image, so as you know, it's a standard question which we all face even in Viva. 30 degrees angulation, Frankfurt horizontal plane. So patient's head should be positioned such that Frankfurt's horizontal plane is 30 degrees below the horizontal plane. It's only at this position that the soft palate is at maximal downward and forward position, functional position, which helps us to record it efficiently. And flexion of head also helps to prevent aspiration of impression material and saliva. That's another added advantage we have, right? Moving on to the next topic, Poisson's ratio. So what is this Poisson's ratio? Poisson's ratio is expressed as, I didn't get the options, but anyways, Poisson's ratio is a ratio of transverse contraction strain to longitudinal extension strain in the direction of stretching force, right? So let me know the options. We'll review it and we'll update the same, the description part of the video if necessary. Right? Moving on to the next topic, penultimate topic. Lisping is seen in which malocclusion? You might have seen many patients or even your friends with class 3 malocclusion having this lisping. Difficulty in pronouncing the letter S especially. So we'll go through some literature pertaining to this. A severe class 3 malocclusion may be associated with distortion or interdentalization of sibilant and alveolar speech sounds S, Z, T, D, N, and L due to difficulty in elevating the tongue tip to the alveolar ridge. The sound most likely to be affected is yes. This is probably because production relies on precise placement of tongue tip in addition to availability of sufficient space in the anterior portion of the palate. Right? Now, final topic. Prodrug, antiplatelet drug, which is also a prodrug. So clopidogrel as well as ticlopidin, both these are antiplatelet drugs which are also prodrugs. They have to be converted into active forms within the body. So clopidogrel is second generation thienopyridine that inhibits platelet aggregation. It's an inactive prodrug that requires hepatic bioactivation via several cytochrome P450 enzymes. And ticlopidin is also an effective inhibitor of platelet aggregation. It's a prodrug that is metabolized to an active form which blocks the ADP receptor that's involved in G2B3A receptor activation, leading to platelet aggregation. So clopidogrel as well as ticlopidin, both are antiplatelet drugs which are in fact prodrugs. Right, so these are some of the topics which some of the aspirants sent me just few days ago. So we worked up on these topics, and if at all you have any additional topics, do let us know. We'll work on them and we'll come up with a next part if necessary. I hope it's clear.